Hi all, this is your Dr. House of Pelvis, and in this series of videos, we will be discussing about cardiotogography or non-stress test. In this video, we will be mostly discussing on what is the introduction to cardiotogography, how is it different from non-stress test, how the misinterpretations led to unnecessary cesarean sections, and even today it's happening, and how do we avoid that by learning the normal fetal physiology and linking cardiotogography with it. So going on, the term cardiotogography is used. Cardio is for fetal heart rate, toco means uterine contraction, and graphy is plotted into a graph. So the relationship of changes in the fetal heart rate with respect to uterine contractions that is plotted in a graph is called cardiotogography. And uterine contractions obviously are present during labor. So back in those days, they wanted to know whether the baby is capable of managing the stress of the labor during which the baby is supposed to highest amount of hypoxic stress, and can it withstand that amount of hypoxic stress or not needs to be evaluated, because there were babies who were having normal fetal heart rate, but after they were born, after 2 to 3 years, they were found to have cerebral palsy. And being an obstetrician, this is a very big medical legal litigation that we have to all go through. So then came in around 1960s, they tried to develop a test called as non-stress test. Okay, why non-stress test? So what is the stress? The stress is nothing but fetal hypoxia. So the stress in non-stress test is fetal hypoxia. And now this fetal hypoxia is usually caused when the blood supply to the uterus is reduced. So how will the blood supply to the uterus reduce? When the uterus undergoes contraction, the blood supply from the uterus to the placenta reduces. So the stress by which they tried to cause fetal hypoxia was by reducing the supply to the uterus, that thereby causing fetal hypoxia, and this contraction to the uterus was brought in by starting oxytocin. So yes, I can simulate a labor and see if the baby is actually managing the stress or not, but unfortunately, pitocin, the lovable drug and the love hormone, is category X drug. Yes, we use it during termination of pregnancy. We don't use it as a drug in pregnancy. So we cannot give pitocin during the process of pregnancy. So there came the point. I need to cause uterine contraction. I need to see how the baby responds to uterine contractions. At the same time, I cannot give a drug that causes uterine contraction. Okay, there comes a smart analysis. They found a device which monitored the fetal heart rate and plotted as a graph and tried to derive some patterns in it, by which they saw that if these patterns are present, the baby usually survives better. So in around 1960, the cardiotogography or the non-stress test came into existence, and when it came into existence, it came without any backing randomized controlled trials. So that is the baseline problem. So because there were no randomized controlled trials, there were no universal guidelines. So based on what people saw, based on the outcomes that the babies were coming out after plotting the graph, they retrospectively went and told that this pattern is normal, this pattern is abnormal. That's how they derived. Until in around 1970s odd, where American College of Obstetrics and Gynecology came with the first set of guidelines describing the decelerations as early decelerations, variable decelerations, and late decelerations, and how their presence will affect the baby's outcome. But because people have not correlated this with fetal physiology, there is an unnecessary action that has been taken on normal variations that happens, that leads to increased number of cesarean sections in one side. On the other side, because of too much interventions that happen, a small atypical variable deceleration that has set in, because of the fear of medical legal litigations, we immediately take the baby for cesarean section and intraoperatively nothing comes out. The baby is completely fine. The baby is postnatally completely fine. At the same time, there has been normal fetal heart rate patterns that has been traced out. But post-operatively or postnatally, the baby develops seizures because we were just happy that the heart rate is between 110 to 160. So somewhere in 1980s is when we started to realize, yes, we need to go one step higher and actually try to correlate this with fetal physiology and try to understand how things evolve and what is the reason for baseline heart rate, what is the reason for beat to beat variability, what is the reason for acceleration, what is the reason for decelerations. So in around 1990, the FIGO guidelines came into place, and that's the first time where they correlated this with fetal physiology and try to eliminate patterns and rather tell how the things progresses, how the baby's physiology progresses, and how fetal heart rate pattern changes as the hypoxia evolves. So this will be the first part of the video where I have told the importance of interpretation of CTG, and in the next video we will be discussing on understanding fetal physiology and eventually how fetal physiology is linked to non-stress test. Keep following, keep learning, and keep teaching.